going to get us kicked off today by just letting you know that what we're going to do, kind of our approach to today's launch. And also to thank you so much for allowing Docs with Disabilities to co-sponsor this. Docs with Disabilities is an initiative that looks at research, education, collective leadership, and the sharing of stories to make change. Under our umbrella, we have several initiatives, or several programs rather, including Access and Nursing. And Access and Nursing is one of our newest programs. It's a nationally representative group of nurses, nurse educators, disability resource professionals, faculty, and researchers that all come together to address barriers in nursing education and practice. And we're extraordinarily lucky to have several of our folks as part of this issue. And really quickly, I want to do a land acknowledgement. I in Chicago right now, and it's located on the traditional unceded homelands of the Council of the Three Fires. The Ajobi, Adawa, and Potawatomi nations, many other tribes as well, call this area home. And this region has long been the center of Indigenous people who gather, trade, and maintain kinship ties. Today, it's one of the largest urban American Indian communities in the United States that resides in Chicago, and members of this community continue to contribute to the life and the fire of this city and celebrate their heritage, practice traditions, and care for the land and the waterways. I will turn it over now to our amazing leaders.
Well, that's a high bar. Well, thank you so much, Lisa. And we are so grateful for your groups hosting this celebration of the publication of our newest issue of the journal. I want to acknowledge the work that has been done on this issue by our guest co-editors, you, Lisa, and Brigit Carter, whom I'll introduce officially in a moment. I'm joining you from my home in Minneapolis, where I live on the land that's the traditional and legal homeland of the Dakota people, and where the Anishinaabe people, also known as Ojibwe, which Lisa mentioned, and others also lived and continue to live. The Mississippi River is right outside my window, and it's a place that's particularly sacred to the Dakota people. It's called Owamni. It means swirling water. It was a waterfall. And a renewal is going on there right now. I'm personally committed to supporting and honoring their ongoing legal and spiritual connections, and I want to also speak for our journal. Our editor-in-chief, Ahtisham, Younas, and I, and our editorial board are committed to presenting voices of Indigenous experience, including wisdom and knowledge of healthcare that has been marginalized or silenced altogether in the past. Issue number 3 for this year was called Indigenous Voices, Sharing Our Stories and Leading Change. It was a wonderful issue. Most of our authors were Indigenous, and our launch event had people from the US, Canada, but also Australia, New Zealand, and Hawaii, Indigenous people. And it was just a wonderful issue. So on behalf of the board of Creative Nursing, the editorial board, Creative Nursing, a journal of values, issues, experience, and collaboration. That's our official full title of our journal. I welcome you to this celebration of the publication of this issue. We have a growing community of scholars with our journal. There are thought leaders who are willing to write about and talk about challenging issues. Some of this is discourse that many journals avoid, but we, on the other hand, welcome it. We don't seek out controversy. We don't go looking for it, but we make space for it when it comes. It's so exciting for me to see the authors in this journal issue who have published with us before, including Brigit Carter, Anne Daroon, Lorraine Stiefel, Amy Koch, Ahtisham, Younas, and Shahzad Inayat. And if I missed anybody else, we love you all. In this publication year, our overarching theme is amplifying seldom-heard voices and dismantling oppressive structures. And we've been doing a lot of amplifying of seldom-heard voices, listening for narratives that are often suppressed or discounted. Issue 1, the value of case studies, we highlighted this undervalued methodology that's ideal for working to understand and support advocacy for people whose voices are seldom heard. That issue emphasized the uniqueness of each individual as the main character in their own story. Issue 2, Mental Health in the 21st Century, reported on the effects on our spirits of the increasing stress, complexity, and change, even since I wrote those words a few weeks ago. What can I say? That seemingly are coming faster than we as a species can adapt to them. So those articles from 12 countries showed that these effects are being felt all over the world. All those articles illustrated in some way the concepts of mental health as a continuum. It isn't that you're either mentally healthy or you're not. It's a continuum, and our functioning in the world as a measure of our mental health. I told you about in issue number 3, Indigenous Voices. The recordings of the virtual launch events of these issues, along with the annotated tables of contents that summarize each of the issues, they are on our website, and we will be posting that link in the chat. So please do go there and look and see all the riches that we have. This is being recorded, as you were notified, and when it's ready for prime time, it will be posted on our website as well. And the presenters can use this in their portfolios. So this issue 4, is called Shaping a New Narrative for Disability Inclusion in Nursing. It focuses on people with disabilities who are another example of seldom-heard voices. Those who are or want to be nurses and those for whom nurses care. When we started planning this issue a year ago now, I think, Brigit, it's been a year since this topic was proposed. Our focus was on disability inclusion in nursing education, because really we're talking to ourselves. We're talking to our own, the nursing instructors and the clinical preceptors and managers and potential fellow staff nurses who have trouble wrapping their heads around the concept that a person with a disability can do nursing. But when we saw the other wealth of other articles that we had about practicing nurses who have disabilities and about disabilities among the people in our care, we expanded that issue to include those stories as well. That's why you will hear articles not only about nursing education, but other things as well. Ableism in nursing education has kept out generations of people with disabilities, and our profession is the poorer for it. In this journal issue, we hear the voices of content experts about structures and processes that are needed to enact true inclusion of people with disabilities. We hear varying degrees of inclusion extended to people with different disabilities. And so in my own editorial in this issue, I have a chance, I have the blessing to comment on each issue in my role as editor. And here's a little bit of what I say, and then I'll end there. I included personal experiences at the bedside. What I say is, all of us have biases, including what we think others are capable of. That's one of our biases that can be explicit and can be implicit. So for 29 years, I practiced in neonatal intensive care, which is one of the most challenging practice environments for just physical logistics and communication. And I'm asserting that nurses who use wheelchairs probably are not going to be into doing helicopter transport, as I did for many years. I've learned that one of our presenters has a daughter who is wishing to be a nurse and aspiring to be a nurse who has a seizure disorder. Someone with an active seizure disorder may not want to do helicopter transport. But what I say about newborn intensive care is, with reasonable accommodations, can nurses with disabilities do any of the other roles that are in NICU? Primary nurses, charge nurses, preceptors, managers, can they do that? I was a preceptor for 28 of those 29 years, and I say absolutely. In any setting, can a nurse who is hard of hearing with assistive technology auscultate breath sounds with the best of us and then decide what to do about what they hear? Of course they can. Can a nurse with clinical depression, with the right support, give expert, compassionate, patient and family-centered care? Can you doubt it? And then one other anecdote. When I was a nurse manager of a hematology oncology unit, one of our really experienced nurses developed MS, multiple sclerosis. She was able to work 8-hour shifts, but she needed a shift off in between. So what that meant is that on her weekend on, she only worked either Saturday or Sunday. And according to our work agreements, if we work a weekend, we work Saturday and Sunday. But we had enough people on our unit, either casual people or people who had a point who were looking to pick up extra shifts. We were able to meet our staffing needs just fine without costing the healthcare organization any extra money. And of that wonderful staff, one person complained to me about it. And what I said to that person is, when you develop MS, you come to me and we'll make accommodations for you too. But until then, I wasn't quite so polite. But for everybody else, all of the others, it was just a part of our staff, and it worked out just fine. And if it starts to not work out fine, you deal with it then. So in this issue, we have what we call general interest articles. Creative nursing has been a themed issue for decades, but we also have articles come through that don't fit a particular theme that's coming up, but they are wonderful articles that we find worthy of publishing, and we don't want those authors to have to wait until an issue comes along that their article fits in. So we publish these articles. It's called Online First. When they are ready for prime time, they are published. They're out in the world with DOIs and indexing, ready to be shared and cited. And then when an issue comes that fits their theme, we include them in that. But we don't want to wait too long, so we have 3 articles in this issue that are called general interest articles. And what they have in common, the theme that they have in common, is that they have that spark of creativity that causes us to accept them for our journal. That's what they have in common. We have such riches to discuss today. I won't say any more about it. After all the articles have been presented, we'll have a moderated open discussion with an opportunity for questions and comments for individual authors and your thoughts about the theme of this issue. And we also encourage you to reach out to the authors personally. We're going to be posting their emails in the chat, the corresponding authors. So please reach out to them with questions and comments. The digital version of this whole issue can be found on our journal's website, along with the annotated table of contents, and then the recording will be posted on our Facebook page, our website, and the Docs with Disabilities website. And we'll post those links in the chat as well. Now, one little plug. I encourage you to read the full text of all these wonderful articles. We are a hybrid issue. Some of our articles are open access. The majority are not. You need a subscription. And if your library doesn't already have a subscription, if you go to our website, right on the right-hand navigation bar, there's a link that says recommend to library. So I'm just saying. I'd now like to introduce Brigit Carter, our guest co-editor for this issue, and the invaluable coordinator for many of these virtual launch events. Dr. Carter is Chief Access and Engagement Officer for the American Association of Colleges of Nursing. So take it away, Brigit.
Thank you, Marty. This is always such an honor and pleasure to hear from all of our authors. I am so grateful to Dr. Meeks for the amazing work that she's done as co-guest editor of this issue, something that I hold near and dear. My co-author on my article, Supporting Deaf and Hard of Hearing Students in a School of Nursing, Lessons Learned, is Rebecca Margrave. Unfortunately, she had an urgent request to assist interpreting a medical assessment for a deaf patient. So if you wonder what our nurses are doing, there you go. So of course we will accommodate that. Her recording was a little too long for us to share. So maybe we can share that in a different way. We can maybe connect it to our recording or something. But anyway, I do want to just give you a brief update on what our article was about. Becky actually attended the School of Nursing, Duke School of Nursing, when I was the program director for that school. And I will tell you, there are many questions people have about what graduates of our program will do with certain types of disabilities. And I say that's not our business. If they would like to go into nursing, there's many things they can do. As we know, nursing is very broad and we can achieve a lot. So then we just had to address what were some of the challenges that a student who was hard of hearing, in Becky's case, requested interpreters, ASL interpreters. So navigating that for the classroom, for the clinical setting, in the laboratory, all the different situations that our students are in, and even just for social events. We have clubs and things like that that students participate in. So making sure that they had interpreters during that time. As Marty indicated, providing them with the equipment that they needed to be able to hear breath sounds and heart sounds and be able to interpret those and talk with their clinical instructor about what they were hearing. So this article basically is just some of our lessons learned. I'd encourage you to read those lessons learned, but most of all, for us to be open and not to say we can't, but to say absolutely, let's see what we can do. And I can't should be the last thing that we say when we have really investigated whether or not this is something that a potential student could accomplish. But by first saying I can, and us not being that barrier to education for those students. So I won't say any more. I am going to now turn it over to Dr. Meeks to play the video for Lorraine Stiefel, listening to the voice of laryngeal dystonia, advocating for the inside out.
I believe Lorraine is here and is going to present.
Yes.
Yes.
Oh,
Yes.
okay. I'm sorry.
That's
I'm
okay.
very sorry.
Yes. Good morning. All right. As I continue to speak, you'll notice my scratchy voice. We don't need the slides yet, though. They're at the very end. So we can just hold the slide till the very end. Thank you. All right. As I continue to speak, you'll notice my scratchy voice. Sometimes it's almost natural, normal, other times not. What I'm saying is I cannot depend on my voice. Some people will say to me, "Oh dear, I hope you're feeling better soon." Other people come up to me and say, "What's wrong with your voice?" They just come out and say it. Well, the short answer is I do have a voice disorder that's been known as spasmodic dysphonia. However, last year, laryngology experts updated the terminology. So now I have, to be more accurate, laryngeal dystonia. And we know dystonia is a movement disorder. So laryngeal dystonia is a movement disorder of the larynx. And I have the most common of 5 types called adductor laryngeal dystonia. So when my vocal cords come together or adduct, to help me speak, they spasm. Well, research is being done to find the reasons for the spasms. We don't know if it's genetic, although I will have to say, when my mother was in her older years, she did develop this. Researchers believe that LD is an interruption in the nerve signals from the brain to the vocal cords or larynx, as well as neurochemical alterations in the basal ganglia. There's no cure, but the gold standard of treatment is Botox injections into both sides of the throat, into the larynx, into the specific muscles. And the injection is EMG guided, but it's still an art to have Botox injections, because not only does the physician have to hit the right spot, he has to know what amount to give you. Typically, it's 2 milligrams. One time I had 2.5 milligrams, and I could not talk for 5 weeks because Botox weakens the laryngeal muscles and stops the spasms. There are some side effects, for example, breathy sounding. Think Marilyn Monroe, very breathy sounding. And you have to be careful not to aspirate liquids for a few days after the injections. They last anywhere from a month, from 2 to 3 months, on the average 15 weeks. But so far, for the past 3 years, I've been going every 10 weeks or so for injections. So, why is it important for nurses to know about these voice disorders? Well, they are on the rise. 1 in 8 adults in the US, has a voice disorder. And as far as laryngeal dystonia is concerned, it meets the Americans with Disability Act definition of a disability when it substantially limits major life activities such as speaking or communicating. It also challenges people's communication, self esteem, and even their lives. And I'd like to give you some examples to make it more real to you regarding self esteem. I have an inability to speak in a group discussion. It's a challenge because in our culture, we talk over each other and we interject ideas. My voice doesn't often work, or it's difficulty starting to work, so that when people are in a discussion, by the time I get a chance to say something, they're on the next topic. So I have a choice then. Should I try to make myself known or not, which can then affect my self esteem? Regarding life threatening events, 2 years ago, I underwent chemotherapy. I thought I would have no problem, breeze right through it because I had it before. Luckily, my daughter insisted going with me, and the IV drip was started. The nurse left the room because everything seemed fine, and then I started feeling strange. Well, I whispered to my daughter to get the nurse. I do not have the ability to yell. So she was my patient advocate as I was slipping into anaphylaxis. She literally saved my life. So you can see the need for a patient advocate. Um, and so let's go on to the slides, which you can read on your own. But I would just like to point out to you, as Marty said, we need to guard against disability bias because if we don't know what our biases are, how can we then care for patients in an unbiased way? Okay, next slide. Uh, I would also call your attention to providing very important resources to patients and also to look at them yourselves. Dysphonia International is a wonderful organization that provides information for people with voice disorders as well as the general public and healthcare providers. They provide online support, in person support groups, as well as Zoom meetings. And it's just a wealth of information plus research. Then the Job Accommodation Network will give great information about work accommodations that can be provided. Practical implements can be used. You can look at an alarm bell or something at the bedside if the call light is not working. But during my chemo incident, you could see how a bell would not have worked. Patient advocate was necessary. And finally, I would say I carry a whistle with me because I go to places, New York City for one, where you're not always in the safest spot. I can't yell. So I have other ways to get my voice known. And I'm challenging nurses to help people with voice disorders to get their message across. Thank you.
Thank you so much, Lorraine, for sharing your story and the importance again of bias. And we're going to move on to our guest co-editor and your editorial.
Thank you so much. And thank you for the opportunity to write about something that I'm very passionate about, and I'm excited to share it with you. I had two co-authors, Ann Lewis and Brandy Jackson, both co-chairs for the Access and Nursing program that I was speaking about earlier. So, what I think is happening is that individuals with disabilities, all types of disabilities, are trying to come into our environments, but there's not a lot of compliance happening across different institutions. And to make things worse, the institutional successes that are experienced, like both Marty and Brigit discussed, are very siloed. So people don't know about these particular cases or how access was made possible. And on top of that, we have, and you'll read about in this issue, we have outdated technical standards, clinical accommodation barriers, disability resource professionals that are marginalized at their institutions. So they're not given the power or the respect to really make a difference in that space. And then faculty who don't understand or lack the legal understanding of disability inclusion, and are unable to process how to make everything work in that space. And then the result of this is that the students often are the individuals who really shoulder the burden of having to advocate for themselves and propose accommodations instead of there being experts in the space. So one of the things that we wanted to do was we wanted to build a community where there was multiple forms of expertise and bring people together globally to create new ideas that would then contribute to greater access across all nursing schools in the US and abroad. And to do that, we brought together so far over 100 nurse educators, learners, and leaders, and have been able to have some very early success. One of the things that I think is so helpful is when you have multiple people that represent multiple roles in the institution and you are all co-leading in a space, there's a respect and understanding for the expertise that people hold, and kind of egos and hierarchy are put aside so that we can accomplish a lot of things in a relatively short amount of time. So, coming together in this space as a team, we were able to publish the first accounting of disability and accommodation use in US medical, or sorry, that's my day job, US Bachelor of Science programs in the United States. And that work was led by Brandy Jackson and published in JAMA Open. So we were able to, as a group working across institutions, we were able to not only collect this data, and if you look at the author list, you'll see lots of learners as well, which is something we're very committed to. We were able to collect the data, analyze the data, write up the data, and have it published because we had so much expertise in this space, working towards a shared goal. We were also able to, in partnering with Brigit, provide two highly attended webinar series, and these are available on our website. So one is on clinical accommodations, and the other is on technical standards. So these were proof of concept that not only are people very hungry for this information, that by coming together and kind of removing the sideload approach that has historically been there, we're able to accomplish a lot more. And not only by coming together across institutions, but by coming together down the traditional hierarchical roles and working side by side. And in this space, what people reported was not only that they were creating something that was meaningful to them and impactful to nursing education writ large, but that they also felt a sense of belonging that they hadn't felt when they worked in other spaces. That for the very first time, many of these people that worked and that are part of our 100 are individuals with disabilities, nurses with disabilities. And so just having that sense of community was really, really important and surprising, I think, to them. I think in other spaces, they had been marginalized, as we've heard from so many people, and felt like their expertise in this space had not been elevated. But that is one thing I think we do really well. As well, we were able to disseminate, not only create information, but disseminate it broadly and quickly, which is something we really need if we're going to make a difference in this space. And I encourage everyone to sign up for the Docs with Disabilities um, website, and you'll find this video and other resources available on our YouTube page, and you can follow us on social media channels. But you can subscribe to our website and you'll get newsletters, and the newsletters always include all of the amazing things our Access and Nursing program are doing. So thank you so much for your time, and Brigit for your and Marty for your mentorship and for the ability to share what we're doing over at AIN through a commentary.
Absolutely, absolutely. And I have so enjoyed working with Dr. Meeks and partnering with her for webinars and getting that information out. We will continue to do that and support docs with disabilities in any way that we can. We appreciate your support. So I am going to move now into Dr. Amy Koch, who is my dear colleague and friend. Navigating health when sudden blindness occurs, the experience of Leber hereditary optic neuropathy.
Thank you so much. I hope you're able to hear me well.
Yes.
Great, perfect. All right. Thank you to, again, Marty, Brigit, and everyone at Creative Nursing who helped bring this article to publication. One of the members of the author team, Melinda Marsh, is also out in the audience. So thank you for being here. Let's see, we can go to the next slide. All right, so Leber hereditary optic neuropathy, you'll hear me condensed down to LHON. This is a mitochondrial genetic disease that causes or can cause profound central vision loss with color impaired. And it's kind of different for every person who experiences it. They might have blurry vision around the peripheral, like you can see in the image below, of normal vision and potentially LHON vision. Because it's a mitochondrial genetic disorder, that means that a mother who has this passes it to all of her children. Now, there's variance of how the participants, people with the disease, the genetic disorder, may show that they have the disease. Many generations may go by, and no one in the lineage knows that they have this disease until someone experiences sudden severe vision loss. And now, this sudden severe vision loss often occurs in the literature that we have in males between the ages of 15 and 35. So people moving along their education, people moving along their employment, and then all of a sudden within 2 or 3 weeks, they can no longer see out of one eye, and then the other eye follows within a couple months. So it's very sudden and pretty severe, so they're unable to do what they normally were doing, maybe working as a mechanic, working on computers, working as a CNA, as one of our participants had been. So they may not know that they have this until they present with it. And because it is known to be rare, it's difficult to diagnose. So as many disabilities go, the shock and distress follow when sudden vision loss occurs. And it impacts the person not only with their mental health, but their physical health as well. So I'm going to talk about the last bullet point later on, so we can go to the next slide. The methods of this study, it was a qualitative descriptive approach, and we had multiple virtual focus groups on Zoom and interviews to explore common experiences and themes of what it was like for a person to experience sudden severe vision loss, what their experience at the time of diagnosis and years to follow. Our sample size was 27 participants. We had 18 male, 9 female. And the ages of our participants were 25 to 91. However, the people who were in this study all had experienced becoming affected with this LHON disease, which was the effectiveness was the loss of vision. And that happened anywhere between 10 to 58 years old for males that were participating and 24 to 88 years old for the females who were participating. And we had a code book of the thematic analysis that we used to go through all of the the data that we gleaned. The code book included desired interaction with healthcare provider, financial impact, impact of disability on personal daily life, interaction with healthcare provider, patient's perspective on their disability in relation to others, and policy and services. All right, and then from our codes that we used in our transcripts, we moved on to our results, which you can go to the next slide. And in these results, this is very busy. Now, as I'm talking, you can read through the speaking bubbles of theme 1, theme 2, theme 3. These are just a little smattering of some quotes that participants said. And they're obviously in all qualitative research, there were so many very rich quotes. But theme 1 is this impact of blindness on daily living. And we glean that there are many injuries that happen. You know, once you're able to see, and then a couple weeks later, months later, you're not able to see as you were. So everything gets impacted. People had injuries falling off curbs, injuries in the kitchen, getting burned in the kitchen because they weren't able to see like they used to be able to see. Participants described how injuries occurred to their bodies due to having to adapt to the sighted world as an individual with a new vision loss. Transportation, not being able to drive, had the biggest impact on independence and impacted employment. Theme 2, there was a great deal of trauma from such a loss. Lack of facial recognition beyond family and friend networks was especially challenging and emotional. Given our societal expectations of recognition of others, it was a big loss for people not to be able to recognize someone's face. One gentleman talked about how he was unable to notice someone from across the street when he's on a walk, and he didn't want people to think he was mad. Other people talked about it's difficult to date because you go to meet someone and you don't know exactly what they look like in person, or job interviews and such. Folks talked about the first 1 to 2 years was extremely difficult after becoming affected. And although subsequent years were also difficult, but those first 1 to 2 years were especially difficult. They had to relearn many aspects of life, including how to financially provide for themselves and their family. And then theme 3 really focused on their experiences with healthcare providers or friends or family. Oftentimes, there was this disbelief, especially with healthcare interactions, that the person really wasn't blind or didn't lose their vision, because it was difficult to tell just by looking at the optic nerve or just by looking in the person's eye as an optometrist or ophthalmologist, until they went to the neuro-ophthalmologist, where they really finding success in getting a diagnosis. So this diagnosis can take between a month or a couple months to almost a couple decades, because it can be difficult to diagnose without a genetic test. People endured multiple tests, multiple different diagnoses, a brain tumor, multiple sclerosis, and had to triage through these diseases when really it was LHON. So the next slide. All right, so what we can do, and the importance of this article being in Creative Nursing Journal, is to help our nurses know that we do have an impact on our patients. We can believe our patients. It's imperative for us to work alongside and provide guidance and connect them to state, local resources for rehabilitation, like learning how to use white cane, learning how to cook safely, and how to protect themselves from injury and cope from the loss. Implementing a focused nurse case manager is a method that we think would be really beneficial for patients who have this disease, and help them gain more quality of life and independence if utilized in neuro-ophthalmology clinics or in other aspects that can connect the people with this disease with the resources needed. So thank you so much for being here today.
Thank you, Dr. Koch. And we will move into our video for mothers' experiences of providing complex home-based care from Masami Tanaka and Yuta Koto.
Good afternoon, everyone. Today I will talk about my study titled Mother's Experiences of Providing Complex Home-Based Care for Children with PIMD. Using a phenomenological approach, I'm truly grateful for the opportunity to share our research with you all. I am a nursing faculty member in Japan with clinical experience in NICU and home care, specializing in phenomenological research. Children with PIMD live with complex medical needs. In Japan, advances in medical care and the expansion of home-based medical service have led to an increase in the number of children with PIMD. While some are hospitalized, many live at home, where their parents, especially mothers, provide intensive daily care. However, even professional nurses often struggle, not because of lack of skill, but because care at home is shaped by emotions, relationships, and silent understanding. This study aimed to explore how mothers understand and care for their children in ways that go beyond medical knowledge. I used a phenomenological approach based on Heidegger's philosophy of care, interviewing 5 mothers raising their children at home. The first team was focusing on child, not on knowledge. Mothers often felt that nurses relied too much on manuals. For example, a nurse might insist on repositioning every 2 hours, but a mother chooses to let her child sleep because she knows that rest brings stability. Medical practice based on medical knowledge reduced the flexibility of nurses and prevented them from focusing on the subjective experiences of children. The nurses' reliance on medical knowledge and inflexible attitudes led mothers to question the adequacy of the nurses' care. The second team was listening to the voices that cannot be heard because the children cannot speak. Mothers attend to the smallest signals. Mothers deeply appreciate specialists who treat their child not as a case, but as a person with dignity. Specialists who focus only on medically necessary reduce without acknowledging the child's existence. We are often less able to notice changes in the specialist condition of children who could not express discomfort on their own. The absence of clear definition of care for children with very severe illnesses, along with the recognition that individualization of care is inevitable, provides important insights. While individualization has often been viewed as a challenge, this study suggests that it is not only unavoidable, but also a potential source of new knowledge and understanding in care practice. In conclusion, mother's care is not merely technical, it is existential. Their caregiving is an act of being with the child, affirming the child's presence. For nurses, learning from parents' tacit knowledge can help transform professional care into something more humane and collaborative. Thank you very much.
So grateful for our colleagues in Japan on this important work. And now we're going to move to Brandy Jackson, who will be reconsidering the need for technical standards and embracing competency-based education in nursing.
Thank you, Brigit.
Okay.
I would like to start with a great shout out to the amazing authors on this paper: Elizabeth Davis, Dion DeMille, Rachel Deere, Sarah Thingage, Kathleen Tilton, Riley Bethcall, and Lisa Meeks. And also a special thank you to pioneers who have done this groundbreaking work before us, and to Creative Nursing for this issue. So when we began planning this paper, we agreed that simply repeating what's already known about technical standards just wasn't enough. We saw these standards as outdated and wanted to explore a new direction. Competency-based education, or CBE, offers that promise, a framework focused on demonstrated proficiency rather than physical traits. Our goal became clear to present an alternative approach for schools to consider. While we recognize that this may not be a fit for every program, we hope it inspires educators to think outside the box when evaluating technical standards. And stay with this slide here. So technical standards in education are non-academic criteria used for admission and progression in nursing programs. They traditionally focus on abilities such as hearing, visual, communication, motor skills. These standards were first introduced following a 1979 legal case, Southeastern Community College versus Davis. And it was done with the intent to define essential abilities for safe practice in the workplace. Medical schools, after that 1979 case, quickly adopted tech standards, and then nursing education followed, often viewing technical standards as gatekeeping tools tied to perceived safety and licensure requirements. However, technical standards are not required by accrediting bodies, are frequently confused with workplace essential abilities, and can create significant barriers for students with disabilities. Next slide, please. So some of the problems that we identified with technical standards in nursing education is they do have that narrow focus, which can exclude qualified students from entering and or completing nursing programs. They are based on ableist assumptions about capability. There's no consistency across programs, which leads to confusion. They are often misaligned with equity and inclusion goals. And importantly, tech standards are just not required for licensure or accreditation. Next slide, please. So competency-based education shifts the focus from physical traits to demonstrated mastery of essential competencies. CBE provides clear, measurable outcomes. It promotes equity and transparency. It aligns with AACN essentials and supports inclusive learning through accommodations. CBE actually evaluates performance rather than assumptions. It removes outdated barriers, prepares graduates for real-world practice, encourages a diverse workforce, and fulfills ethical obligations outlined in the ANA Code of Ethics. In our paper, there is a table that crosswalks the 6 technical standard domains to the AACN essentials, the AACN competencies. Next slide. So our key takeaways through writing this piece were: technical standards are outdated and exclusionary. Competency-based education offers a fair, inclusive, and effective model for nursing education. And our call to action became very clear. First, retire technical standards and replace them with competency-based education. Second, definitely need to invest in faculty development through resources and training, as this would be a big change in nursing education. And third, align program policies with principles of justice, equity, and inclusion. And finally, foster transparency so students understand expectations and can plan for success. Thank you all for listening, and I'm going to turn it back to Brigit.
Thank you so much. I could stop and talk about each one of these, but for the sake of time and having questions and answers at the end, I'm going to move forward. We now have a recording from Samta Pandaya and on young adults with achondroplasia.
Young adults with achondroplasia, self-esteem and well-being, examining the impact of dance sessions and augmented dance sessions. The background is that achondroplasia, the most common form of dwarfism, is a lifelong condition, and impacted persons often face issues of health and well-being. For this cohort, the effectiveness of arts-based programs such as dance or augmented dance sessions need to be studied. The method that was followed was, for this non-equivalent comparison group quasi-experimental study, the impacts of dance sessions and augmented dance sessions comprising added spiritual content, both delivered online, on the self-esteem and well-being outcomes of young adults with achondroplasia were compared. The dance sessions cohort comprised 30 young adults. The augmented dance sessions cohort comprised 31 young adults. The dance sessions were delivered by dance trainers. The instruction mode was online synchronous group sessions of 30 minutes duration, twice a week for 20 weeks, and asynchronous homework recommendation twice a week for 20 weeks. The content comprised warm-up exercises involving slow and light rhythmic movement of limbs and stretching, free dance style to slow instrumental music, and preparing a choreographed dance on a popular music selected through mutual consensus. The augmented dance sessions were delivered by dance trainers and meditation trainers. The instruction mode was online synchronous group sessions of 50 minutes duration, twice a week for 20 weeks, and asynchronous homework recommendation twice a week for 20 weeks. The content comprised prayer or sitting in simple silence, instant relaxation in sitting position with deep breathing, tree posture, that is standing still and centering in tree posture, warm-up exercises involving slow and light rhythmic movement of limbs and stretching, freestyle dance to slow instrumental music, preparing a choreographed dance on popular music selected through mutual consensus, and deep breathing sessions in which there was a focus on flow of breath and the rhythm. This was accompanied by instructions to live in the present, appreciate the surroundings, things about the self, thoughts on meaningful others, appreciating meaningful relationships, and build compassion for others. The last part of it was deep relaxation in supine position. Homework for dance sessions comprised practicing the repertoire once individually prior to the next synchronous session. One MP3 file with recording of the music was used during the preceding synchronous session, was sent to all participants through WhatsApp on their respective mobile devices. Homework completed or not completed had to be self-reported by the participants onto a Google form. Homework for augmented dance sessions also comprised practicing the repertoire once individually prior to the next synchronous session. One MP3 file with recording of the music used during the preceding synchronous session and instructions during the deep breathing exercise was sent to all participants through WhatsApp on their respective mobile devices. Here also, homework completed or not completed had to be self-reported by the participants onto a Google form. The results indicated that participants of the augmented dance sessions reported significant improvements on self-esteem and well-being outcomes. The comparison cohort, however, who did the dance sessions alone, did not have any significant post-test outcome score changes. Gender, education, and program compliance were significant predictors of post-test outcome score changes of the intervention group. Discriminant analysis suggested that young adult females, those with higher formal education, postgraduate or vocational degrees, and those whose program compliance was higher, that is, those who attended more than half the augmented dance sessions and attended corresponding homework sessions more than half the times gained the most. Conclusions are that with an added component of meditation, dance can be a creative, community-based intervention that nurses may use in working with young adults with achondroplasia. Augmented dance sessions with added spiritual content are thus impactful for diverse participants. Implications for nursing practice. For nursing professionals and creative nursing practice, results practically imply that nurses can play a collaborative role in identifying needs of young adults with achondroplasia who seek care, treatment in hospitals and healthcare settings, as well as in community setups. Nurses can urge clients with achondroplasia to join the augmented dance training as a self-care and therapeutic mechanism. Further, with adequate emphasis on program compliance through attendance and homework completion, augmented dance sessions are effective in improving self-esteem and well-being of young adults with achondroplasia. Some modifications would be needed for male participants and those with lower formal education.
All right, thank you so much. And I do not see Ahtisham yet. Is he? You're nodding, Marty.
He will be coming, but he may not be here yet.
Right, so we can come back to this. We'll move forward with the recording from Dr. Stephanie Getzik-Nyman and Ann Darwin, ensuring access for all nursing students.
Hello, everyone, and thank you for allowing myself, I'm Stephanie Getzik-Nyman, and my co-author, Dr. Ann Darwin, to be with you virtually today to review some highlights of our manuscript entitled Ensuring Access for All Nursing Students, Classroom Accommodations, and Universal Design for Learning. About 1/3 of U.S. adults have a documented disability, and of that 1/3, about 14% experience cognitive-related disabilities. Many folks will pursue post-secondary education, which is not exclusive or does not exclude nursing education. Unfortunately, nursing programs face several challenges for individuals who need accommodations, such as our traditional inaccessible, inflexible standardized assessments, limited faculty training and exposure to learners that have documented disabilities, and which negatively impacts our disabled learners. Relying solely on the legal obligation of providing accommodations can unfortunately delay support, cause stigma, and miss the needs of those that are actually choosing to undisclose their disabilities. So our hope is that by learning more and sharing with you some strategies from Universal Design for Learning and instruction, and having this embedded into course design will help foster greater inclusion, reduce actual needs for accommodation requests, and build better belonging among our learners. Many times faculty are looking for kind of a one-stop list of what exact accommodations can I or should I provide to the student. And unfortunately, because accommodations are tailored to that student, there isn't such a master list that exists. Jackson et al. In 2025 did a survey of BSN programs and found that among those participants, the most common accommodation was extended test time. Additional accommodations that were found also documented were breaks without penalty, providing tests in alternative environments from the rest of the classmates, providing readers for those exams, and also alternative exam formats. We, in our article here for this manuscript, did summarize some additional information on common testing and other classroom accommodations that might be found in Table 1. It's also important that if we do have learners with documented accommodations, that we help them secure them as much as possible through their specific state board of nursing as they pursue licensure. So our hope was to spend a little bit more time with you today and in the manuscript looking at the concept of universal design for learning and instruction as a way to bridge this gap between faculty and learners with disabilities. UDLI, Universal Design for Learning and Instruction, is defined as the design of teaching and learning materials and environments that are accessible and usable by everyone without requiring modifications or specialized adaptations. This helps intentionally support learner agency, encourage greater active participation, and reduce those learning barriers. So by reducing that and having this universal design and this infographic, I think does a nice job of kind of thinking about all the pieces of universal design for learning, helps to reduce perhaps the need for folks to disclose their disability, which would then also the consequential stigma that is sometimes associated with that disclosure for the learner, as well as sometimes the large amount of time it takes to implement an accommodation when it is requested, or the marginalization some folks unfortunately experience due to getting perceived differential treatment. So what are some proactive UDLI strategies? Well, some of the main sections that are in our manuscript are listed here for you. Of course, starting with the physical environment and all the places and spaces that our learners exist. That would also include looking at your emergency action plans to make sure that they are usable and accessible to all and safe for all of our learners. Making our course plans and learning assignments flexible as much as possible, as well as varied in the way that things are presented, helps to address differences in age, learning styles and preferences, life experience, and people's different abilities. We should also consider posting our course materials as soon as possible before a course begins so that learners can plan ahead, ask for additional questions or support for assignments that might be challenging for them, either based on their needs or what's going on with their life currently. Also, syllabi, it's important to have standardized language about accommodations that uses inclusive language versus stigmatizing language. Another really big piece that we spent a large part of the manuscript talking about and developing a table, it's table 2, is looking at all of the visible resources, including our own presentations that we use in the classroom and all of our visual materials to make sure they are truly accessible. We have pulled some resources that are making standardized recommendations about all of these things: text size, color, captions, transcripts, things like that, that can be really helpful for nursing faculty to make sure their presentations are accessible by all. And then, of course, making sure that we have good student engagement so that way those communication channels are open. And as we interact with those learners, we'll learn more about their preferences, challenges, and also valuable insights into maybe other accommodation needs that have not been addressed yet. So universal design for learning, we really see as a stairway for more inclusive nursing education. It's providing a nice framework. Other disciplines have leaned into this, and we're hoping that nursing will also do the same as a way, again, of including all of our learners to promote more empathy, critical thinking, greater workforce diversity, our better patient outcomes, and overall more accessible learning environments for all of our nursing students. So thank you so much for your time today, and we hope that you find the manuscript and this presentation helpful.
Wonderful. We really appreciate their contribution. We're going to move forward with Lori Brody's video, Access in Nursing Education.
Hi, my name is Dr. Lori Brody, and I am honored to present to you today some information about our article for creative nursing. As you can see by the slide, I worked with an amazing group of individuals who all contributed to our article, Access in Nursing Education, the Interactive Process for Determining Disability Accommodations. I'd like to thank Michelle Lopez, Brandy Jackson, Abby Parrish, Dion DeMills, Sarah Hine, Riley Bechtel, Lisa Meeks, and Ann Lewis. Together, we worked very hard to really identify some of the barriers, some of the myths, and some potential solutions for the interactive process in providing accommodations in nursing education. The goal of our article was to clarify the accommodations process, delineate stakeholder roles, and advocate a legally grounded, inclusive approach to nursing education. Often in nursing education, administrators and faculty can feel that it is their responsibility to be gatekeepers of the profession, for example. We are hoping that through this education and information in the article we submitted and that's published, we can help to clarify the roles, the very interactive process, and how each stakeholder plays an important piece in the process. So those roles include DRPs, which are disability resource professionals. They lead the legal and procedural aspects of accommodations, ensuring there's appropriate support and ensuring appropriate confidentiality measures are in place. Students are also active participants in the interactive process. Students are required to initiate the process, their own request for accommodations. They will submit and provide documentation, and they maintain open communication because their needs may evolve over time. Faculty must then uphold the legal obligations, apply accommodations appropriately, and collaborate with DRPs to maintain the curricular integrity. And our clinical partners play a role in preparation of clinical sites and positive framing of inclusion, as this is essential to implementing effective, context-aware accommodations. There are legal and conceptual frameworks to consider. Foundations are grounded in federal law, such as the American Disabilities Act and the Rehabilitation Act. The purpose of accommodations is to eliminate barriers that exist in nursing education. The definition of reasonable accommodations must preserve the academic standards. So any accommodations that are approved and implemented must not compromise the integrity of the academics in the program itself. And then there is a very significant importance on personalization. Accommodations is not a one-size-fits-all process. It is individualized, specific to the person who is requesting the accommodations and their individual needs. It is also important to remember that one disorder does not yield the same accommodations for every person. Challenging ableist myths is another aspect of our paper that we felt was very important to bring to light. Some prevalent myths that exist are assumptions that accommodations somehow lower standards or risk patient safety. We know that that is just a misbelief. The reality of clinical performance is that research shows students with accommodations perform effectively and safely in clinical settings when they are properly supported. There are legal and ethical mandates. Some people believe that accommodations may be optional, when in reality, there are federal and ethical mandates to ensure that there are accommodations made without providing unfair advantages. And then institutional ableism, which includes the rigid technical standards that have really resulted in bias and assumptions. We need to replace those with inclusivity and policy developed to allow for expanded access. In conclusion, our recommendations include adopting inclusive teaching practices, investing in faculty development, enhancing institutional policies, and a commitment to continuous improvement as we expand the access to nursing education for everyone. Thank you so much.
Brigit, you're on mute.
Thank you for telling me that. I'm just talking away. Now we're presenting Tess. And Tess, I didn't want to mispronounce your last name, so I'll let you do that. And you'll be presenting on Good Disabled Company.
Hello, everybody. My name is Tess Carrickner. My visual description, I'm a white woman with dark hair and glasses. My paper was Good Disabled Company, a disabled student perspective on nursing school. Next slide. Thank you. So there's kind of three main takeaways that I talked about from my experience as having multiple disabilities and going through a 4-year undergraduate program. I'm graduated and now work as a hospice nurse, and I'm in a PhD program. But what I learned is that there's a fine line in talking with multiple other students who are navigating the disability accommodation process. Many students come to college having had accommodations in high school, but they're not necessarily accommodations that they had to register for. It's something their parents did or a school counselor helped to initiate. They may have been 7 when they first got accommodations, and they haven't had to update. There's also diagnostic disparities. For example, people, I study mostly like intellectual disability and autism. Women are much less likely to receive access to diagnosis. People of lower socioeconomic status, non-white people as well. Anecdotally, when speaking to various students trying to access accommodations, sometimes there's inconsistencies in who they're communicating with the accommodations offices, or they're asked to corral a lot of medical paperwork that they might not have access to. It's something their parents have. Of course, there's the concern with privacy and people knowing that you have a disability if that's not something you're ready to tell. And then trying to explain kind of your case, like why you are quote unquote disabled enough to deserve accommodations, but not quote unquote too disabled to be a nurse. So we had a great presentation about universal design for learning, and this is a great way to kind of avoid these uncomfortable sort of situations for disabled students by instead creating an environment that really works for everybody. Next slide. Thank you. So something that I also noticed during nursing school was that oftentimes when we focused on various populations, disabled people are not always recognized as a population. Instead, we're kind of dispersed among other populations, and that identity is not recognized as being social in nature. So it's important to teach that historically disabled people have been targeted as a population, and it's important that we understand these things so that we can prevent them from happening in the future. There's a really good example of this happening during COVID with the deprioritization of people who received ventilators based on quality of life and whether or not they had intellectual or developmental disability diagnosis. Another idea is to teach multiple models of disability. So beyond the medical model, talking about the social model, the biopsychosocial model, the money model of disability. And then lastly, the collaborations with community disability organizations that I experienced during undergrad really helped me to understand the actual day-to-day life of people with different disabilities. And there are many of these resources that already exist and are very easy to put into curriculum. The Autistic Self-Advocacy Network provides many, and so does Michigan Medicine's Deaf Health Talks. These are free public resources. Next. Lastly, so I led a group in undergrad called Disability Justice at Michigan, which was predominantly nurses or nursing students, but was also open to everybody. And the two goals were to introduce an anti-ableist perspective into nursing school curriculum and to create a place of belonging for disabled students. We had guest speakers. We built a library of anti-ableist texts related to health and social identity. We had Paralympic watch parties. We even contributed to the creation of a published anthology. Next. So in conclusion, nursing schools do have the power and choice to utilize universal design for learning and revise accommodation processes and try to do their best to promote disability culture among students, whether that's through funding clubs or providing opportunities with collaborating with outside organizations. And then lastly, students should not have to navigate processes that are demeaning in accommodations, and instead should be approached or should instead approach the environment through a universal lens. Thank you.
Yes, thank you so much. I'm so honored to actually have you here and to hear your perspective. And it connected very closely with Dr. Getzig-Nyman's and Dr. Ann Derwin's article. So thank you so much for that. And we are moving to our editor-in-chief, Ahtisham Younas. Turn it over to you.
Thanks, Brigit. Well, pleasure to be here. I'm just going to start off with our first article. This is choosing an analytical approach in qualitative descriptive studies. In nursing, we tend to use a lot of qualitative descriptive studies. It all started, I think Margaret Sandalowski wrote a paper in 2000, which talked about how qualitative descriptive studies are a type of designs where there's less interpretation compared to other type of interpretive designs. And then in that paper, she talked about content analysis as one of the approaches for analyzing data in qualitative descriptive studies. But then she wrote a revisited paper in 2010, and then she clarified some of the assumptions or that people had about lack of interpretation. Like people thought like qualitative descriptive studies, there is no interpretation at all. But then she clarified like, well, even quantitative data, there is interpretation. So you can't have qualitative studies without an interpretation. So anyway, this paper was looking at how you analyze your data. So generally, people would know that content analysis is one of the ways of approaching data analysis. But then this is the fourth article in the series. We briefly talked about phenomenology. We talked about narrative inquiry. We talked about grounded theory. We've talked about a couple of other designs and case study methodology. It was the idea of these editorials came from the fact that there were a lot of papers that were submitted to us. Most of the papers, they were always issues with data analysis approaches. So we wanted to give people clear idea like how they can go in. And again, this is just our perspective. So briefly in this paper, we outline what qualitative descriptive studies are. So we describe that there is also interpretation in qualitative descriptive studies. And then we clarify how people can choose between content analysis and thematic analysis. So again, there is also a lot of misconception about thematic analysis, which originally was developed by Miles and Huberman, but then Braun and Clark's paper that was published in 2006 went really viral. And everybody kept citing the same paper over and over again, and without realizing that there are different types of thematic analysis. And then Braun and Clark wrote several papers correcting those misinterpretation and telling people that don't say that thematic analysis is one broad method, even though there are three different types of thematic analysis. So in this decision tree, we give people an idea like how you start up with your epistemological stance and an ontological stance, and then your primary focus. So if you're interested in, if you're going aparadigmatic, which means you don't have any epistemological ontological stance, then you can go straight away choose content analysis for qualitative descriptive studies, which are generally looking at experiences, perspectives, and events of research participants from their perspective. And then if you follow some type of paradigmatic stance, then if you are more positivist, which is believe in a single reality out there, or more of a realist stance, then you can still choose content analysis. But if you're more interested in a constructivist type of stance where we think that knowledge is generated when we work with people and then understand from their perspective, then it's better to choose thematic type of analysis. And then if you're interested in only the content as it is presented, then content analysis perhaps is a better approach compared to thematic type of analysis. And then again, thematic, there are three types. There's coding reliability type of method, there's codebook method, and there's reflexive TA. And then generally people would even say, for instance, one of the common thing that you would notice in a lot of qualitative descriptive studies that are published in nursing journals, people would say that they use thematic analysis, but they won't say that what type was used. And then they'll say that two people independently coding the data. Now they are referring to coding reliability TA, which is not the same as reflexive type of TA, where you bring in your own reflexive perspective. And then there's looking at more of like there are no code books and you don't even need inter-rated reliability as done in other type of TA. So we just try to clarify some of those misconceptions about qualitative descriptive studies and how you choose the analysis approach that's best suited for your specific study. So I'll end there, and I hope this probably is useful for a lot of nursing researchers out there who frequently use qualitative descriptive studies. I use quite a lot of qualitative descriptive studies. So hopefully we think it's probably going to be useful for this as well. Thank you.
Thank you so much. And we'll come back to you in a minute, but right now we're going to introduce Younas Massey. His article is actually one of our general interest articles, and we consider this an exemplar of our journal's mission that highlights creativity in nursing. So take it away.
Thank you for this opportunity. The published manuscript title is Undergraduate Nursing Students Engagement and Associated Factors in Classroom Learning. And I will talk about its background. Can you move the slide, please? Okay, please, background. Next slide. Okay, so there is a lot of pressure on institutions, on higher education institutions, to provide a quality of education, and nursing profession is continuously evolving, and there is need of much more approaches that can help to engage the students most in their classroom learning. So this is student engagement is a critical component in nursing education, and it can increase the retention and academic performance of the student nurses. So, okay, after reviewing the literature, it came to know that most of the previous studies are secondary data analysis studies, and they have not looked about the student engagement in academic years. So with these views, we have this the purpose of this study was to assess the undergraduate nursing students engagement levels and the associated factors, and then compare the undergraduate nursing students engagement across academic years. Next slide, please. So for this study, we choose the analytical cross-sectional study design. There was 341 bachelor students, undergraduate nursing students, and this study was conducted in private nursing school or nursing college in Pakistan. And the sampling method was consecutive sampling method, and we selected 291 nursing students for this study, and the response rate was 95%. And for the data collection process, we selected the student engagement questionnaire that was given by Kimberly and Lewing. And then after the analysis, we have findings from this research. Can you go to the findings, please? Next slide, please. Okay, so there were 198 females and 78 males, and they were mostly the students were with high level of engagement in the classroom learning, and there was also some across academic years, across semesters. In the 7th semester, there were also higher levels of student engagement, and they were also self-directed learning. They were engaged. The higher levels of engagement was in self-directed learning, adaptability domains, and there were moderate levels in student and teacher relationship and student-student relationships, and there were also differences across academic years regarding critical thinking and student health. So there were also other factors that were limiting the student engagement in classroom, that included the health of the students and family pressure to choose the profession, and their intent to be in the profession. And because this is considered as least choice for them, so this was the also a factor, and socioeconomic status factors were also there. So with these findings, please move to the next slide. Next. So with the implications in nursing, the findings of study are helpful for nursing educators and nursing institutions because they can develop effective teaching and learning strategies that can promote the student engagement and making learning environment more conducive to enhance student engagement and also help in promotion of critical, creative, and problem-solving skills among nursing students and promote their mental, physical, and emotional health as well, because they have to work in the clinical setup. So clinical settings. So this, if they are strong by their mental, physical, emotional health, they can work better and prove themselves as a better workforce. So this was the study all about. And thank you, Creative Nursing, for helping me to disseminate my work. And
No,
these are references for this. And thank you.
thank you so much for your contribution as well.
Thank you.
So I believe next we have Ahtisham. Are you going to be doing the brief review of the remaining articles, or Marty?
Let's do Christine first. Christine Gannon.
Okay, I'm sorry, I don't have her on my list.
This slide
I
is
know she's here.
this
So
is
Christine Gannon, we will move with you.
yes.
Thank you.
Hello, everyone. I'm Christine Gannon, and my co-author is, hello, I'm Dr. Dae Kun Kim. Nice to meet all of you. And thank you for including us in this. I appreciate the opportunity for all of us. We can go to the next slide. All right, so our project looked at exploring using a graphic novel for increasing mental health awareness. As a lot of us know that, mental health issues are on the rise, and so that was something we wanted to explore. I want to stop and acknowledge my language. Generally, in my environment at Gallaudet University, we typically pick one language, but because I'm talking about working with deaf and hard of hearing, I want to sign, and also because my co-author is here who's deaf, so want to provide complete inclusion. But at Gallaudet, I would typically sign only, but because the majority of you are hearing, I'm going to speak, and so therefore I'm going to use both at the same time. Want to also acknowledge that I'm a white woman with red glasses and long brown hair and a blue background with a kind of relatively purple shirt. Okay, we can go to the next slide. So we used a graphic novel to look at exploring how to increase mental health awareness for our deaf and hard of hearing students. All of our participants were deaf or hard of hearing, and we had around 20 participants. It was a qualitative case study, and students were assigned to read the book and then had some reflections that they had to fill out, and then we came together to discuss the book and the impact of the book. And what we found was there was really 4 primary themes. The first was that students felt very engaged with the book because it had more pictures and less text. It made it more accessible for our students, especially since they were college students. It was really important that they were able to read it fast and easily rather than having to kind of like navigate through heavy text. We also found that they felt very connected to the text and to the pictures. They felt that the author's experience and the way that the author explained their experience, that they felt that they could relate to it either personally or through friends and family who struggle with mental health. They also recognized that some of their experiences being deaf and hard of hearing were different than the authors and wanted to see more of their experiences reflected in the graphic novel. And then lastly, for the book itself provided a lot of coping strategies, and they were able to connect with a lot of those different choices, and they were also able to add other coping strategies that they used. Okay, get to the next slide. So there was one more slide. Let me open it up here. Give me 1 second. So, even though this might seem a little bit different than some of the other articles on nursing, I think so there's several different important points for why this is relevant. I think the first thing is that a lot of us are seeing impacts to mental health in many different settings, and really trying to find different ways to address mental health in ways that do not consume a whole lot of time or allow us to provide additional resources. So by finding additional materials such as this book or other creative strategies can help us to really address mental health in different settings, including nursing. And because we're looking at deaf and hard of hearing where we don't always have accessible communication, to be able to have other kinds of materials that allow for bridges for communication. This is a potential resource that we can use to work with deaf and hard of hearing students and people in general. And then the last thing I'd like to acknowledge too is that a lot of our deaf and hard of hearing community members want to become nurses. And so being able to figure out ways to include them in the nursing environment, but then also recognizing the stressors that nurses and nursing students experience, it's really important to recognize mental health and to find different resources that we can use to provide our nursing students and the nurses themselves. So thank you very much for having us here. I look forward to any questions at the end.
Yeah. Thank you.
Good job.
Great. It was great work. And now we will move to Ahtisham. And then after this, we will have time for questions and comments.
Thanks, Brigit. Okay, so first I'm going to talk about the article by Tatiana Porliaka and the co-authors. So this article is about exploring discharge preparedness of patients with stroke. It's a qualitative descriptive study. The authors conducted unstructured interviews with about 100 people who had stroke, and then they used reflexive thematic analysis to understand the patterns and themes in their data. And then the three key themes that they talked about were like general post-hospital concerns, and then concerns of patients regarding ability to handle their activities of daily living, and then post-discharge aspiration and goal. I think the key aspect of this study, or the key findings, that the takeaway messages that are posted for readers, are generally like looking at enhanced discharge planning. So there is a need that discharge planning should be tailored based on patients' needs. And then improving support for activities of daily living for individuals who experience stroke. And then incorporating patients' personal aspirations into care plans and advocating for comprehensive post-stroke care, because a lot of patients also raise concern that the quality of care that's provided to those who experience stroke is somewhat alarming, in a sense that it doesn't really meet their expectations. So that's why incorporating their own personal inspirations and their viewpoints into care is really instrumental to improve the quality of post-stroke care for them. Then the second article is by Human Muhammad Talibi, and then they talked about analyzing the strengths, weaknesses, opportunities, and threats using SWOT analysis, which is commonly used in a lot of nursing and healthcare literature. And they were interested in seeing how chatbots have been used in emergency nursing. It was a narrative review of literature. They looked at 16 different studies published from 2018 to 2024. And most of the studies were identified through literature search in PubMed, ScienceDirect, and Google Scholar. The key results that they highlighted were, in terms of, again, SWOT analysis and strengths, were that chatbots can improve decision-making and help reduce nurses' workload. But the weaknesses are the chatbots cannot really recognize or correct inaccurate data, especially when there are complex or high-equity situations that nurses work in. And then opportunities include integration with electronic health record and predictive tools to support better care. And then the key threat would be ethical and legal. And we're already seeing that a lot in terms of how AI or chatbots have been used in clinical settings, and that there could be potential over-reliance, which may restrict the effective use of chatbots. And the third article is by Dr. Saleh Salimi and then Farinaz Mohammedzad. This is from Turkey. It focuses on transformative teaching practices, real-time feedback for dynamic classroom engagement. This was a descriptive cross-sectional study that was conducted in Turkey. They included 48 second-year nursing students who were enrolled in a compulsory surgical medical course. And then they looked at students' understanding, engagement, clarity, pace, visual aids, and real-life example with different interactive activities that they proposed in the classroom settings. They sought feedback from students, and then lecturer also provided feedback to students, and then the students gave feedback over how lecturer taught them. The key things that they talked about was in terms of practice, they highlighted that how real-time feedback tools can really improve teaching quality. And then it enables an immediate adjustment based on student input. In terms of research, they highlighted that we need to look more into the development of effective feedback tools and explore strategies to reduce negative impacts, particularly in terms of lecture time pressure and decrease student engagement. I think it somewhat links to Younas' study of student engagement as well. And then in terms of policy, they highlighted how institutions would need to consider incorporating real-time feedback system into faculty development programs so that to ensure that the teaching learning process and the strategies that educators or lecturers are using are student-centered and based on the needs of the students. So thank you very much.
And I would like to present the final article. Am I understanding that Dr. Valdez and her co-author were not able to submit?
Correct.
Okay.
Correct. And we're sending healing thoughts to her. She's not feeling well,
Yes,
so
indeed.
we're thinking about her.
Well, then I would like to briefly share with you about this article because it's so wonderful. The title of the article is Disability, Intersectionality, and Visibility in Nursing. And the authors are Ana Maria Valdez. She's a professor of nursing at Sonoma State University in California. And her co-author is Andrea Dalzell, who is the founder and CEO of The Seated Nurse. Both of these nurses have disabilities that they talk about within this article. So due to a lack of access and awareness, nurses with disabilities are often left out of nursing initiatives that are designed to increase equity, diversity, inclusion, and belonging. Other groups that have been marginalized or minoritized are often invited to the table, but nurses with disabilities often are not. Disability often intersects with other minoritized identities in nursing as well as in society. But there is pretty scant research about intersectionality among people who have disabilities. In this article, the authors, one has an apparent physical disability. She uses a wheelchair, and the name of her organization is The Seated Nurse. And the other has a non-apparent dynamic disability. They share their personal experiences showing how disability intersects with other marginalized identities to create unique and compounded barriers. And then they highlight how disabled nurses navigate these intersectional discrimination, exclusion, and invisibility factors in both educational and professional settings and personal settings too. And they emphasize that disability is a natural part of human diversity. That phrase is what I used as the title of my own editorial. So I'll say it again. Disability is a natural part of human diversity. So these authors call for nurses and professional nursing organizations to reimagine equity, diversity, inclusivity, and belonging, to include the experiences of people with disabilities, and to ensure access in nursing.
Yes. And we couldn't have ended on something more beautiful. And thank you for all the contributions of our authors. But one of the things that, we're open now for comments and questions, but I just wanted to start off by saying one of the things that I'm working on right now is in my job is really about trying to help people understand our goal should be access for all, not access for some. If we think about it more broadly, then we won't have these marginalizations of identities. We need to really think about when we are creating a course or we're looking at content, or we're doing clinicals, we're doing sims, how are we making sure that we are providing a space where everyone can see themselves engaged in that space? And if we start thinking about it from that perspective, I mean, there's a lot of things that are done that we don't even think about. And Dr. Gannon, as you were signing, I'm thinking, wow, why don't we just have that as a part of what we do, right? Because we don't know the levels of hearing. We don't know the people who have not self-identified. And so I just think we have to be more open. And I'm going to leave it at that because I want our people who are in attendance, if you have any comments or questions, and Marty has her hand up. So Marty, go ahead.
I'd like to say two things. And one is a shout out and grateful thanks to Michelle Schneider, who's been doing our
Yeah.
real time, generating these wonderful captions. What a challenge and what a gift that you are giving us. Also, I want you to know that I pasted the email addresses of the corresponding authors and into the chat for everyone, and also the places where the recording is going to be found. I can do that again. Well, no, actually, here it is. So, so please use these resources. That's all I'm saying.
Yes. And now we're open for comments. So if anyone in our listening audience has questions or comments, if any of our authors have any additional comments, now is the time. We have about 15 minutes before we close out. Go ahead, Dr. Gannon.
These were all wonderful presentations, so thank you all for sharing. It was really awesome to be able to learn from all of you. And I think the learning that I kind of take with this is that it's hard to anticipate and know all of the disabilities that you have to include, and how to be inclusive for all. So that we should always be learners, and that we should always be open to continuing to learn, to be able to figure out how we can ensure that our teaching, our work, our services are inclusive, and that should be kind of a lifelong process. So thank you for being part of my learning process.
No, and I agree, we can't anticipate everything, but if we open our minds just a little bit more.
Absolutely.
That's what I'm asking. Go ahead, Tess.
Just wanted to say that it's very encouraging to see so many people who are really dedicated to this. I mentioned it in my paper, but at my school specifically, having champions for disability access and education is really what allowed the members of Disability Justice at Michigan to graduate and now work as nurses. So each of you is very important in, making that happen for the students you interact with, or the research that you make that people who interact with students read and learn from.
Yeah. That's where I definitely feel like our training, our bias training is really important. And that's something that I don't know. I think because it's been commonplace, people don't really think about it in this space, but we have to recognize our biases so that we can, think about how we're approaching different things in education, in the clinical setting, wherever we are. So Dr. Meeks, do you have anything to add? I'm not going to leave you out.
Well, and I always have something to add. So
Yeah.
I always
Yes.
have a thought, many thoughts. First of all, I want to offer gratitude to the nurses. I have not traditionally worked in nursing. I am not a nurse, and the nurses, the 100+ nurses and nursing students I've been working with, have taught me so much. And just on this particular event today, I feel like I've learned even more about the work that's being done in the nursing space. And I have a lot of gratitude for both the historical work and to see so much ongoing work. So thank you very much. I also, not to single you out, Tess, but I really think for those of us who are in the work, who are doing it, who are faculty members, or working on the wards, to see that there is a next generation of people that will be able to carry the torch that was lit by the people before us, it gives me a lot of peace. And so I am particularly always grateful for the next generation, the nursing leaders. And I'm also reflecting on how important it is to have spaces like creative nursing where you might be bringing a new concept or something that is not salient in the literature to the reader, and these new kind of outside of the box ideas, which makes up so much of what disability inclusion is. So I'm very grateful to Marty and to Ahtisham for providing this space and hosting this journal. And I've learned a lot through this process. So thank you.
We thank you so much as well for, openly accepting the guest editor. We're so grateful. And I know I've worked with you for a while now, and I'm just so grateful for your leadership and guidance in this work as well, and support of nursing.
Thank you.
Marty, you're muted, my friend.
Sorry. I've had a chance to talk a lot already, so I don't want to use up other people's time if they want to comment. But I want to just share with you something as the person who does the final copy edits of all of the articles and is quite involved in communicating with all the authors. I don't often cry when I am doing this work. I laugh a lot, and sometimes I go, but the article from Japan by Yuta Koto and about these children with the profound disabilities, there's a link between that, the discussion of disability, and our discussion of our methodology that's been ongoing all year. Phenomenology as a methodology is by definition the study of human existence. The philosophers that inform phenomenology, that is what they say. We are studying human existence. Well, what these two authors say is that these children, many of them are graduates of newborn intensive care units where I worked for a large part of my career. They are now at home being cared for by their mothers, and many of these children can't even communicate. Some of them cannot even move on their own. And what these authors say is these children in previous, up until now, would not have survived. But because of our technology, here they are with us. And they, in a way, are a new form of human existence. And so these authors are studying how these mothers care for their children, how they learn through what the authors call tacit knowledge. They learn what their children need. And the problem is when their children go into the hospital and are being cared for by doctors and nurses who don't understand, they don't get it. It isn't the medical knowledge that doctors and nurses have that is the enemy, that is the antithesis of the kind of care the mothers are giving. It's the inflexible use of the medical knowledge. And one of the anecdotes that the author mentioned in her video is this mother knew that her child could sleep through the night without developing pressure sores. The idea of turning an immobile patient every 2 hours to prevent pressure sores is very important. That's medical knowledge that's very important. But this mother said to the nurses, I know my child. I know that he will not develop pressure sores. So please let him sleep through the night. And the nurses were not able to let go of that rigid turn every 2 hours thing, and the child was the worse for it. And so the link to me, linking this all together, is that we all have to see the child or the adult, the patient, the person, the individual who is in front of us, and not use our biases and just take them for what they are.
Yeah.
Thank you.
Thank you, Marty. That rigidity often is our downfall, right? We become very rigid in our rules, our education, and not open to the needs of various different people. So I think that's so important. There was a comment from Olga in the chat that just says, thank you very much for sharing so many diverse voices and experiences here. as my School of Nursing moves forward with accessibility, I will be sharing these resources with colleagues. And that's exactly what we want you to do. And as Marty said earlier, please, you have all the information of our authors. There's lots of information on Docs with Disabilities website. There are some links to AACN as well. I think we have some of the same recordings on the website, and there's other resources as well. So we thank you so much. And I don't want to close if there's any other comments or well, then with gratitude, I thank you so very much for your presence, for all of your contributions to creative nursing. We are so grateful. And Marty and Ahtisham, we're very grateful for you.
Yes.
Dr. Meeks, thank you so much for your hard work in getting this issue out in the world.
Thank you.